Good morning. So it looks like most of you came back. That's a good sign. Hope you brought your umbrellas today. So this is a great segue from the session that Nicola just talked about. And I love the question about the variants and the definitions. Great eye. So I'm going to talk about the NHSN version of the urinary tract infection definitions. I will have some polling questions if you want to log in on the web or via your phone. And here is the poll everywhere information if you need it. Then here's the web information for poll everywhere. Okay. So our goals for the next 2 hours are for you to be able to describe the benefits of using NHSN for UTI surveillance and reporting, to be able to describe the NHSN methodology, protocols, and definitions used for UTI surveillance and reporting. And then we're going to test your knowledge as you accurately apply these definitions through case studies. So as Nicola just talked about, UTIs are prevalent in the nursing homes. They are one of the most common infections that we see in the nursing homes, with symptomatic UTIs being the most common. So that's your non-catheter-associated. So surveillance is pretty important for these infections. Out of the room, how many of you are currently performing UTI surveillance in your facilities? Impressive. And how many use the NHSN criteria? Okay. So I'm going to talk about today the NHSN criteria, but I'm also going to give you an outline of where some of the variances are from NHSN definitions versus the McGear, so that you have a deeper understanding of the differences. And so we know that UTIs are one of the most common infections in the nursing homes. They account for anywhere from 50 or more % of the antibiotic use. So I think it's great that most of you in here are including UTI surveillance in with your surveillance programs. As you've learned this week, just a quick review from yesterday, surveillance is important because we have to know what's going on in our facilities before we can implement change, right? So UTI prevention begins with surveillance. We want to get that data in front of those policymakers, in front of your administrators, so that action can take place, right? I thought this was interesting. I actually did a talk at APIC and got really interested in the history of surveillance and infection control. And so I did some digging on how surveillance is defined and found these different variations of how surveillance is defined. And it actually, if you look in the American Heritage Dictionary, surveillance goes back to the 1800s, and it was started by the French, when they were using surveillance as part of spying on people. And so, not to bore you too much, but so these are just some of the different variations. But as Dr. I thought I had a point out. So as Dr. Bell talked about yesterday, for the purposes of public health, we really define surveillance as the collection, collation, analysis, interpretation, and dissemination of data. So again, you must have the data to encourage change, right? Something else that I think is really important is, in our country, we can take surveillance for granted because we have resources and we have wealth in many areas. So data is not always required to get action. But if you look at some of the other countries who do lack in resources and who lack in the same wealth, without surveillance, without information, without data, they lack the resources that they need to get what they want for communities and for programs. So surveillance is really important and goes much farther beyond just infection control in the hospitals, if you really think about it. Oh, there's my square. So, why do we perform surveillance? We talked about this yesterday, but for you guys, it's important to know what's going on in your facility. You want to know what infections are most prevalent in your facility, what organisms are most prevalent, what patient populations are you seeing the most infections. You want to identify new or increasing infections. If you have an outbreak brewing, you want to know about it sooner rather than later. And the only way you're going to know about that is through surveillance. For example, do you have a system in place where if an employee, your CNAs call out sick or your nurses call out sick, where you can identify what illness that employee has and compare that to what's going on in your facility? That is an example of surveillance, and that's a great example of how you can prevent a potential outbreak from occurring by just being knowledgeable, knowing what's going on in your facility. And then also highlighting opportunities for improvement. If you know that you have a problem with catheter-associated UTIs and you have the data, then hopefully your administrators, your powers to be, are going to give you the resources, staff-wise, financial-wise, to put prevention processes in place. But you need that data. And then, again, to assess the impact of new prevention strategies. So if you implemented a new hand hygiene program, it's going to be nice to know, does the data support improvement? Are you seeing a decrease in infections related to poor hand hygiene? And then, of course, to comply with regulatory expectations. So we know that surveillance can directly measure what's going on in a population, but again, it can also measure strategies that you've put into place. And I am a true believer in what gets measured gets done, or hopefully it gets done. But if you don't measure it, then you don't know what you don't know, right? So you have to know so that you can put processes into place. Resources, and ideally your resources are going to follow your data. And I think about this too with our politicians. We get, I sometimes will go through the healthcare bills on the table and just looking at what policies are the politicians trying to put into place. And it seems the most informed politicians, the states that have good data, have good advocacy, have the best bills going into place to improve patient safety, improve public awareness. So again, that the policies, it goes far beyond just the hospital and the nursing home environments. By now, you all should be familiar with this slide. We have 3 modules within the NHSN component, and today we're going to focus on the healthcare-associated infection module. And right now, this module does include urinary tract infections, and that is both catheter-associated and non-catheter-associated. As I said yesterday, we are knee-deep, or actually thigh-deep, in this respiratory tract infection module. And so we're hoping in the next 2 years at the most, we're going to have this live. We're going to be doing some field testing. We've developed a form and a draft protocol based on literature reviews and studies that have been done. And so we're going to have field testing this next calendar year. And if all goes well, we hope to push it into NHSN soon after that. And we're also working on the skin and soft tissue infection module. So we have great things coming, and we look forward to getting your feedback. I know some of you in the room have participated in some testing, and with our dashboard for us. We may contact you again if you're interested to help us with some testing of these new modules coming out. So definitely, if you're interested in doing any of that and getting involved in helping us develop great protocols and forms, send us an email and we'll definitely put you on our list. I'd like to keep this slide in here. I feel like I'm drilling this in about the benefits of surveillance, but I like this slide because it allows you to put in your mind, to put in practice what you can do with NHSN. By reporting your data into NHSN using the NHSN definitions, you're able to retrieve everything that you put into NHSN basically, because the application will calculate your UTI data for you and it will be immediately available. So you're going to have access to your UTI rates. You're going to see the great dashboard today. For those of you who were not able to go to the analysis sessions yesterday, you're going to get a sneak preview today. So the NHSN will also give you line list, analysis options. There's just all kinds of things in NHSN that you can do data-wise by reporting your data into NHSN. There's some antibiotic stewardship features built in based on the summary data that you report, and we're going to talk about that as we get more into this presentation. But for example, you're able to look at your antibiotic use in your facility for the treatment of urinary tract infections. You're able to look at your urinary catheter utilization and so forth. Certified skilled nursing facilities and nursing homes, as well as intermediate chronic care facilities for the developmentally disabled, are eligible to report UTI event data. So what I'm going to talk about as far as the surveillance definitions for UTIs, this is going to be different from the surveillance talk we talked about yesterday for lab ID event reporting. Because for UTI surveillance, you're looking at a combination of the laboratory data combined with the constitutional and localized signs and symptoms, right? With the lab ID event reporting we talked about yesterday, we were not looking down on that clinical level. We were really just looking at admission data and laboratory data. So it's different for UTI surveillance. You're going to incorporate those resident signs and symptoms as well as that urine culture data. And you have to have both in order to meet one of the NHSN UTI criteria. We did adopt the UTI protocol from the revised McGear criteria. So you're going to see it's very, very similar. We have made changes over the year based on feedback from our users and some of the data that we see coming in, and really to improve the applicability of using these data for surveillance purposes. So here's a list of some of the differences that you will see, and I'll kind of talk through these a little bit for you. So the first one are signs and symptoms. For NHSN, the signs and symptoms are considered nonspecific. And what that means is that they can be applied to more than one infection cause. Take fever being the most common. If your resident has a fever, and your resident has a positive urine culture, and your resident has dysuria or another localized sign and symptom of a UTI, that resident will meet NHSN UTI criteria, even if the resident has a cough or has an infiltrate on the x-ray, because the way that we view fever is nonspecific, meaning it can be applied to more than one infection cause. Now, when you compare that to McGear says that you must look for other sources of infection before using fever, rigors, or hypotension. So that is one difference that you're going to see. Another difference is the CAM criteria are not required when applying new onset confusion or functional decline to the NHSN UTI criteria. What you're looking for with NHSN is an acute change, not related to another cause, but acute change in that mental status or confusion. Something's not right with that resident. And compared to McGear, the confusion assessment method or the CAM method is required to assess mental status or functional change. Now, with the NHSN, you'll see as we get deep into the protocol, you do have to have to use acute mental status change. You do have to have accompanying leukocytosis as well, but we'll talk more about that. And then, as one of your colleagues pointed out earlier, the urine culture requirements are different between the two. And for NHSN, your urine culture requirements are not dependent on how that specimen was collected, regardless if it was a straight catch, a clean catch, or however your urine was collected. the colony count requirements are the same compared to McGeer, where the urine culture requirements are dependent on how that specimen was collected. For NHSN, the urine culture must have no more than 2 species of microorganisms with at least 100,000 colony-forming units of bacterium. And again, when you compare that to McGeer, you'll see that if the specimen is collected via straight in-out catheter, you can have 100 colony-forming units versus 100,000 if it's a urinary catheter specimen or avoided urine. And then lastly, NHSN does not consider yeast an attributor to a UTI. So yeast is not considered an acceptable UTI pathogen when yeast alone is in the urine. If you have yeast plus a bacterium, then you can use that culture. But if you only have yeast, it does not qualify as a positive urine culture for NHSN. Versus McGeer, there are no exclusions for yeast-only urine cultures. If I could give you 2 pieces of advice for your surveillance program, I would say set your expectations wisely when you're thinking about a surveillance program. So you're sitting in here this week, and I know that there are many of you who are new, and this is overwhelming, especially yesterday when we talked about all those MDROs and C. difficile, and now today I'm throwing UTIs on you. It's overwhelming. And there is no expectation that you're going to leave here and go back to your facility and put all of this in your monthly reporting plan, right? You need to decide what is important to your facility. What are the risks and the benefits in your facility? And the best way for you to set those expectations is look at your risk assessment. What is your patient population? What are the organisms that are most prevalent in your facility? Do you have an issue with UTIs? Because if you don't, then maybe you don't need to add UTI surveillance. Maybe your issue is you have a lot of MRSA in your facility or wound infections. So really set your expectations wisely and don't overextend yourself beyond your resources. So look at your risk assessment and look at your resources to determine what surveillance options you're going to put into place. And the second thing that I would tell you is to institute consistent surveillance definitions. Save yourself the headache of wondering, oh gosh, did I remember to do this? Did I remember to do that? Or if you're transitioning to a new facility, you want to make sure that no matter who is doing the surveillance in your facility, they are applying the definitions exactly the same. So have in place consistent definitions for how you're going to identify infections in your facility. And then once you have that, it'll make it easier for you to more consistently apply the criteria, and it's going to make your data more comparable. You want to be able to stand in front of your administrators and be confident when they say, are you sure our rate was 3.5 in 2018 and now it's 9.7 in 2019? You want to be able to stand in front of that administrator and say, yes, I am sure. We use the same definitions. We apply the definitions consistently, and this is what it is. We have a problem. Here are some considerations if you are going to adopt NHSN UTI surveillance criteria, or really any surveillance criteria for that matter. When you're looking at a resident, you want to identify, are the symptoms new or acutely worse? So did the resident come into our facility with this infection? Because there is that 2-day, I'm not going to report if this was considered present on admission. Or what about the resident who has a UTI, got better, and then is symptomatic again? So you want to ask yourself, is this new or worse? Does a resident have an indwelling urinary device in place? And this is important because the criteria are different depending if that indwelling catheter is in place. So if the indwelling catheter is not in place, there are certain criteria that can't be used to meet the UTI. For example, if there's no indwelling catheter, a fever alone is not going to meet NHSN criteria, versus if there is a catheter, then there's a higher chance that maybe that fever is related to a UTI. And then evidence of infection. that you must always have a positive urine culture to meet NHSN criteria. Are there localizing signs and symptoms? So, for example, a resident without an indwelling catheter and without localizing signs of infection to that urinary tract, chances are it may not be a urinary tract infection, or at least may not meet the criteria, the definition for a UTI. And then, does the clinical presentation meet the NHSN criteria? Again, that goes back to the signs of infection, the localized signs. And Nicola talked about this. If there's a clinical disagreement, you're going to have clinical disagreements. That is almost a guarantee, because when you're looking at surveillance definitions versus clinical treatment guidelines, surveillance definitions are looking at a population based, right? They're not looking at individual residents. So the surveillance definitions do not take into account the individual history of that resident or the circumstances of that individual resident. So, for example, we get questions sometimes about residents who maybe be nonverbal or confused, and how do you identify a UTI in those residents, and why don't our criteria accommodate those? Well, again, because the criteria for surveillance are designed to look at a population, so we're not able to add each and every one of those specific nuances that may occur. So there does have to be some clinical judgment involved when you're looking at the UTI criteria. And when we get into the case studies, I think that's going to help you. So just know that surveillance and treatment and clinical treatment serve two different purposes. And we never want you to treat or not treat a resident based on the surveillance findings. That's very, very important. And we get those questions sometimes where the IPs or the DON will send us an email and say, well, my medical director is treating based on the NHSN criteria or the McGear criteria. And we're like, no, because they're not meant to be treatment guidelines. If you come across a resident and you're not quite sure, or there's some nuances with that resident, but you feel like the resident still does meet UTI criteria, for example, a nonverbal resident who twitches or closes his or her eyes during a lower abdominal exam, and you may feel that's may be suprapubic pain, and you feel that, then that is your decision. This is not NHSN decision to make that. It is your decision. This is your facility. But what I may suggest, and this is for really your internal, not for us, because we don't look at your notes, but make yourself some notes when you submit an event. You have a comment section, and that is really for the next person. So say a new IP comes in behind you and they're validating your events that you reported, just so that he or she can kind of know where you're coming from. Don't be afraid to use the comments, because that box is meant for the facilities. Also, we encourage you, if you have a case that is interesting and you're just not quite sure how to apply the definitions, send us an email with the case, and we will help you. We will give you our opinion if we feel like it meets or not. But again, ultimately, it's your decision how you want to handle that. But we will give you our opinion, and we'll give you a background of why we came to our opinion. So feel free to email us at nhsn@cdc.gov for that kind of feedback. And we actually enjoy reading those cases because it keeps us abreast of the front line, what you guys are going through on the front line. So please don't hesitate to reach out to us. Okay. So now we're going to get kind of into the nitty-gritty with NHSN reporting if you're participating in urinary tract infection surveillance. So we have the UTI monthly participation requirements. Remember this. So the NHSN monthly reporting plan must be completed, again, for each calendar month in which a facility plans to enter data. If you're planning on submitting UTI events for the calendar month, you're going to want to make sure that you're doing surveillance for both catheter-associated and non-catheter-associated, and you're looking at facility-wide, so all resident care locations in your facility. At the end of that month, you're going to submit your summary data, And remember, the summary data must be completed even if you did not report any UTIs. So if you performed surveillance and found 0 UTIs in your facility, you still must complete that summary data. And then lastly, you're going to want to make sure you resolve those alerts each month so that your data are complete and included in your analysis. We talked about this a lot, I feel like, yesterday, but that monthly reporting plan is important because, first of all, you have to have it on file before the application will allow you to enter any events. But it just lets NHSN know what your intentions are so that we know and we can trigger. So it will trigger alerts for you to remind you of things that need to happen so that your data are complete each month. Just quickly, to enter your monthly reporting plan, you're going to log in. Remember your navigation bar here. You go to your reporting plan. You're going to click Add, and this is what's going to populate. You're going to enter your month and year. The very first section is going to be the HAI module, and that is where you're going to find your UTI. And right now, when you go to the HAI module, UTI is your only choice. But when we add the RTI and the skin and soft tissue, the drop down will include those selections as well. So for now, you have the UTI. And then if this is the only surveillance module you're going to follow for the month, you just put a check mark and you click Save. Of course, if you're going to add additional modules, then you would make those selections on that same page. Again, the UTI surveillance must occur for all resident care locations in the facility, and it must occur for residents with and without urinary devices. Sometimes we get this question, especially when a facility has an incomplete UTI event. And what we find is that some facilities are entering UTI events even if the resident does not meet NHSN criteria. And if you do that, then you're going to constantly be getting alerts from NHSN. So it's important that you're only entering UTI events that meet NHSN definition. And I'm going to show you, I have some screenshots and some slides further down that will show you how to identify if your event actually meets the NHSN criteria. So one thing I do want to point out, because this is different from the lab ID metrics, is that you're looking at residents with UTI signs or symptoms presenting more than 2 calendar days after your current admission. So if you look here, if your resident is admitted on June 4th, you're looking at day 1, day 2 don't count. So you're looking for the onset of signs or symptoms on day 3 on. So if the resident comes in and complains of dysuria on day 1, but the urine culture is not collected until day 3, what are you going to do? Count it or not count it? Not count it, because the onset actually occurred. So you're looking at the onset. So the onset is identified as either the first sign or symptom or the collection of that positive urine culture. Which residents are excluded from NHSN reporting? This actually is very similar to the lab ID event metric that we talked about yesterday. You're only including residents receiving inpatient care in your facility. If they're receiving care in another facility, you do not report those UTIs. Again, only residents fully meeting the NHSN UTI criteria should be included, and that includes the positive culture requirement. And then we just talked about residents presenting with signs or symptoms on day 1 or day 2 of current admission are not included in your reporting. Now, if the resident is transferred to your facility from another facility and presents with signs and symptoms on day 1 or day 2, it would be best practice to contact that facility, the IP in that facility, and let he or she know, hey, we just received a patient from your facility and the patient presented with UTI symptoms, because that facility does have reporting requirements that have to be met. we have this nice form that you are able to use for your UTI data collection. If you are new, I do recommend that you have these forms to get you started until you really get used to the data elements that you are collecting. This form has all of the data elements that are required, and it comes with a table of instructions, and the form, like our other forms, is also customizable if you wanted to add additional data elements to the form so that it meets the needs of your facility. Here is the web page for surveillance for UTIs, and on this page you'll have access to the training protocols and forms and instructions, analysis resources, and so forth. Okay, so next I want to talk about a few of the important key terms and definitions you're going to need to be aware of when you're performing UTI surveillance using NHSN. So first is the date of event. The date of event is defined as the date when the first clinical evidence, so those signs or symptoms of the UTI appeared, or the date the urine specimen was collected, whichever comes first. An indwelling urinary catheter is defined as a drainage tube that has been inserted into the urinary bladder through the urethra and is left in place and is connected to a drainage bag, also referred to as a Foley catheter. This does also include your leg bags. What we do not consider as an indwelling urinary catheter are those straight catheters, the in and out catheters that are used to collect specimens or to relieve bladder distension, nor are suprapubic catheters considered, or condom catheters or nephrostomy tubes. Now, if you have a resident with one of these devices, they can still meet NHSN UTI criteria, but they would need to meet the NHSN SUTI criteria, not the catheter associated. And we're going to get to that, those definitions as well. There are two specific types of UTI for NHSN. You've got those symptomatic UTIs or the SUTIs. So those are the non-catheter associated, and then, or the catheter associated. Then you've got the asymptomatic bacteremic UTIs or ABUTIs. So again, both of these will include your residents with and without an indwelling urinary device. So let's talk about the symptomatic UTI first. So this is your resident who demonstrates signs and symptoms that localize that infection to that urinary tract. These events, again, can occur with your residents with or without indwelling devices or other types of devices. And then we do occasionally have those residents with asymptomatic bacteremic UTIs or ABUTIs, and those are the residents who do not display signs and symptoms localized to the urinary tract, but they have a positive urine culture as well as a positive blood culture. That's important. You have to have that blood culture, and at least one organism in those two cultures matches. So that tells you something is going on, right? Even though the resident is not showing localized signs and symptoms, there's an organism brewing in that body somewhere. Okay, so let's start with the symptomatic UTI infection. And this is going to be the non-catheter associated. And we kind of went over this earlier, but for these residents, you're going to evaluate the resident. You're going to identify that the resident does not have an indwelling device in place and has not had one in place in the previous 2 days, right? The resident does have a positive urine culture, and this is where many IPs will start the surveillance. They'll start by getting that positive urine culture. You get that positive urine culture, and then you go digging to figure out what the heck is going on. Does the resident have one or more localized signs or symptoms? When you're looking at infection related to not related to an indwelling device, you really want to hone in and look for those localized signs and symptoms to make sure that whatever's going on with the resident and that positive urine culture is not colonization or something else. You want to make sure that it is linking you to a possible UTI and not something else. So here are the NHSN criteria for what we call a SUTI, symptomatic UTI, without an indwelling catheter. So criteria 1, these are your localized signs and symptoms. So if the resident has acute dysuria or acute pain, swelling, or tenderness of the testes, epididymis, or prostate, automatically meets NHSN criteria. So they can have one of those because those are localized. If the resident has some non-localized, also maybe that fever or leukocytosis, that's fine, but the resident must also have at least one of these signs and symptoms. So the resident must have fever or leukocytosis plus a costovertebral angle pain or tenderness. If you see that, then likely the resident's very sick and has more than just a lower UTI, but it's possible that you will see that. Those residents may be on their way out to the hospital. You may use fever or leukocytosis if the resident has a suprapubic pain or tenderness on examination. If there's visible blood in the urine, if the resident has a new incontinence. Now, this incontinence doesn't count if the resident's an incontinent resident, but if this is a new thing for the resident and you're like, what's going on? Then it very well could be a UTI. And then a new urgency or frequency. And then criteria 3 here, if the resident doesn't have a fever or leukocytosis, they can meet by having 2 of the criteria that I just mentioned. And what I recommend, I don't think I have a screenshot in the slides, but in the protocol, you have these nice figures. I don't know if you guys can see this, but I recommend having these figures accessible because it makes it really easy to follow the criteria. To me, this is a little bit confusing because it's blocked out, but if you use the algorithm, it makes it much easier. And that is in your booklet, in your tabbed booklet that you have, but it's also in our protocol. And then again, you must have that positive urine culture. And regardless of how the specimen is collected, that urine culture has to have no more than 2 species of microorganisms, at least one of which must be a bacterium of at least 100,000 colony-forming units, or 10 to the 5 is how you may see it on your lab report. So let's talk about fever a little bit. We define fever in a resident as greater than 100 degrees Fahrenheit or greater than 99 degrees Fahrenheit on repeated occasions. And so what that means is more than once. Doesn't have to be 5 times, 10 times, just more than once. If you see greater than 99, if you see 99.4 documented at 2 different times, the resident meets that repeated occasion. Or an increase of more than 2 degrees Fahrenheit over baseline. And your baseline should really be based on when that resident was not sick. So maybe the intake form when the resident initially comes in, what was and was not ill, or any medications that impact the temperature. Maybe you use that as the baseline. NHSN does not require a specific route of measurement. So we don't say, oh, it must be rectal or tympanic. It's whatever route of temperature measurement your facility implements. And the temperature documented in the resident's medical record is what you use. No conversion based on the route of collection. We don't ask facilities to do that because it gets confusing, and then it's not easily to compare between facilities. So use the temperature that's documented in the medical record, regardless of how it was collected. And just remember, fever is considered for NHSN reporting a nonspecific sign that can be used to meet more than one criteria. So if there's possibly 2 infections going on in this resident, fever can be used to meet UTI. Leukocytosis. So this is defined by NHSN as an elevation in the number of white blood cells in the blood, more than 14,000 cells per millimeter, or a left shift of greater than 6% or 1,500 bands. It is identified through a complete blood count and a differential blood test, and you may see neutrophilia or left shift documented in the medical record, and that may be a clue for you. So let's look at an example of a SUTI without an indwelling catheter. Mrs. Stevens is a resident of the nursing home. On March 1st, she develops new or increased incontinence and new suprapubic pain. The following day, on March 2nd, a voided urine specimen was sent to the lab and subsequently tested positive for greater than 100,000 colony-forming units of E. coli. Mrs. Stevens does meet criteria for a non-catheter-associated UTI, right? So she has the new increased in incontinence, new suprapubic pain, and she has the qualifying urine culture. Okay, we're going to switch gears a little bit now and move on to catheter-associated urinary tract infection. So this is SUTI. Here's the figure again. So again, you're going to assess if the resident had that indwelling urinary device. And if so, or if not, was there one in place in the previous 2 calendar days? And then you're going to make sure you have that qualifying urine culture, right? And then you're going to look at your signs and symptoms when the resident has an indwelling device in place, the signs and symptoms requirements are not as rigorous. So you can see here, the resident can have any one of these signs and symptoms if an indwelling device is in place. Okay, so the resident may simply have a fever and a positive urine culture, or Rigers, or a new onset hypotension that is not related to a medication or a non-infectious cause. So for example, if the resident has a cardiac condition and a positive urine culture, you have to ask yourself, is the hypotension really related to the cardiac condition, or is it related to the infection? So you're looking for a new change that is around the same time as that positive urine culture. Is there a new onset confusion or functional decline with no alternative diagnosis? If your patient has dementia, you cannot use new onset confusion because it's not new, right? But if this is a resident or a patient who has been alert and cognitive and following commands and all of a sudden stops, then there's reason for you to do a further assessment to kind of figure out what is going on. Now, I do want to point out, if you're going to use, this is the only criteria where you must have 2 for this SUTI. So if you are going to use confusion or acute functional decline, there must also be leukocytosis present. So these 2 must be together in order to use either one of these criteria for your SUTI. And new onset or acute functional decline is not included in the criteria for non-catheter associated. So this is just specific to those residents who have those indwelling devices in place. Your resident can have a new or marked increase in suprapubic pain, or that costovertebral angle pain or tenderness, or have a new acute pain or swelling or tenderness of the testes, epididymis, or prostate, or purulent discharge from around that catheter site. So for these, to meet SUTI, you only have to have one of these categories. Again, the urine culture requirements are exactly the same regardless of how the specimen is collected. So you're looking for no more than 2 species of microorganisms and at least 1 bacterium present. So if that resident has Candida and E. coli, is that a qualifying urine culture? Yes. If the urine culture has Candida only, is that a qualifying urine culture? No. Okay, good job. I want to talk a little bit about hypotension. We get these questions occasionally. Defining hypotension is put back on you all. You want to use the vital signs parameter per your facility policy and practices for clinical practice. So however you define hypotension in your facility is how you're going to apply that definition for your UTI criteria. Again, it is considered a non-specific sign of infection. So if you have a resident who potentially has another infection source, hypotension can continue to be used to meet the UTI criteria. However, if there is a non-infection source related to that hypotension, like a cardiac or a new medication, then you will not want to use the hypotension to meet the UTI criteria, right? Because chances are it's related to some non-infectious cause for that resident. And then we talked about the new onset confusion. You're looking for new. Something is different with Mr. Smith. Something he's not following commands, and he has been following commands, and he's all of a sudden incontinent and he is stumbling when he walks. You're looking for something acutely new. But you do not have to apply the CAM criteria. Let's look at an example with Mrs. Ross. So Mrs. Ross is a resident in your facility. She has an indwelling urinary catheter inserted on March 1st. And then on March 5th, the nurse practitioner documented that she complained of suprapubic pain. The following day, on March 6th, a specimen is collected from that Foley catheter and was sent to the lab, which subsequently tested positive for more than 100,000 colony-forming units of E. coli and then 100,000 colony-forming units of Candida aureus. Mrs. Ross does meet the NHSN criteria for SUTI on March 5th since she has that indwelling device in place, right? And she had at least one documented sign or symptom, and she had the positive urine culture. So we have that indwelling urinary catheter, the suprapubic pain, and then there is your qualifying urine culture. Want to spend a little bit of time on the asymptomatic bacteremic urinary tract infection event. It's very simple, as you can see from my slide. I don't even think you need to print this. It's so simple. So basically, these are your residents who have no localized signs or symptoms, but you have this positive urine culture and a positive blood culture with matching organisms. In that case, you would have an ABUTI to report. And with that ABUTI, when you report that, you're going to report the positive urine culture as well as that positive blood culture. And an ABUTI applies to both catheter and non-catheter associated infections. Now, I don't want to leave you confused between the Bacteremia versus the Bacteriuria, because we're definitely not advocating that you treat asymptomatic Bacteriuria or ASB, because those are not included in NHSN surveillance. And what that is if you have a positive urine culture, no signs and symptoms, nothing else. Would you report that? No, we do not consider ASB as meaningful infections. A lot of times it is colonization, and you will often see these positive urine cultures in your chronically ill residents or your residents who have been chronically catheterized. So we do not advocate treating these residents. We do know from literature that these residents are often overtreated with antibiotics, and which puts them at risk for adverse drug reactions. And what else does it put them at risk for? C. difficile. So very important that you understand that this is not what we're advocating. We're only advocating for the ABUTI, so that positive urine culture with a positive blood culture that's matching. Okay, so now I want to talk about how do we submit a UTI event to NHSN. So you have your monthly reporting plan in place, and you've been out on the floor and you've identified your very first event, and you're ready to submit it to NHSN. So when you log on, you go to your home page, your left navigation, event, and add. Let's say that you have 2 IPs in your facility because you have a wealth of resources and you're not sure if the other IP already entered this event, what could you do really quickly to see? Find. You would click find, and then when you get to the page, I should have put a screenshot, but when you get to the page where you enter the resident information, just go straight to the bottom and click find again, and it's going to give you that line list of everything, not just UTIs, but everything that's been submitted so that you'll have an idea of what's already been submitted. So once you click add, this is the page you're going to see. So the resident information section is exactly the same as what we talked about yesterday. And let's say that you've already entered a CDI for this resident, then all you have to do is enter the resident ID and everything else will populate that you've already entered. You're going to come down to resident type and select short stay or long stay. Again, this is based on the date of specimen collection and the date of first admission. If it's more than 100 days, it will be long stay. If it's less than 100 days, it will be short stay. And then you're going to enter the date of first admission to the facility. So that's the date when that resident first came into your facility. And it does not change unless the resident left your facility for more than 30 consecutive days. And then your date of current admission will be the same as your date of first admission unless the resident has left your facility more than 2 days. If the resident has been out for more than 2 days for an admission, it's very important that you update that current admission because remember, your infections and your categorizations are all based on that current admission date. And then you come down to your event information and you're going to select UTI. And then the date of event. And remember that date of event is the date of onset of the clinical signs or symptoms or the date the specimen was collected, whichever comes first. The resident care location, you want to document the location of that resident at the time of onset. Okay, let's do a knowledge check if you want to get your phones ready. This is going to test if you guys were listening to me yesterday. I am entering a UTI event for a resident in my facility, but when I try to select her resident care location, the drop-down box is blank. What is wrong? So A, the resident doesn't really have a UTI. B, the resident is not really a resident in your facility. You're delusional. Or C, the resident care locations have not been set up for your facility and you must do this before submitting events. You guys do not even need to be here. You're so smart. I think we should let them out early today. Good job. So those resident care locations must be mapped. So that's the first thing you want to do when you get back to your offices this week. If you don't have those locations set up, go ahead and do that. And if you have any problems setting them up, let us know and we will help you get those things set up. Once you select the location, then you're going to select the primary resident service type, which corresponds to the location that you selected. And then here's that same question. Has that resident been transferred from an acute care facility in the past 4 weeks? If you say yes, then you're going to get another box that asks you to be specific about the date of transfer. And then you're going to be asked, did the resident have an indwelling catheter at the time of transfer to your facility? Yes or no? And then actually so yes or no. And if you say yes, it's going to be in place, neither. Oh, no, it's not yes or no. It's in place, neither are removed in the last 2 calendar days. And the reason these questions are in here is this allows you, when you're looking at your data and looking at your UTI data, it really allows you to get an assessment of, especially if you have a large skilled facility, at any residents that are coming in with catheters already in place, maybe UTI brewing. It just gives you an idea of what's coming into your facility and these residents coming in with devices not placed in your facility. So if you select that the resident came in with the device in place or removed in the last 2 days, Then you're going to have a question that says site where the catheter was inserted, and that's going to be your place or the acute care facility. And then it asks you a date, but that is optional. If you don't know the date, you don't have to enter the date. But if you know it and that's data that you are interested in collecting, then certainly enter that. If you select not in place, there's no indwelling device in place, it's going to ask you if there was another type of device in place. And so if you select yes to that, then it's going to give you the option of was there suprapubic or an intermittent straight cath. So you can answer. And again, this just allows you to further analyze, maybe if you're interested in looking at your UTIs associated with your suprapubic caths or your residents who are chronically straight cath. It allows you to look at that data. Then you're going to scroll down, and this is the next section. So you're going to specify the criteria that you use to meet the NHSN definitions. Now, what I want to point out is this is blank, but down here in the little corner, you see where it says specific event. Notice that's blank because this little section is auto-populated by NHSN. We will identify the type of UTI your resident has based on on your selections up here. All right, so it's going to be really important that your selections before you enter up here already meet NHSN criteria. So let's say that the resident has a positive urine culture that meets. So we checked that. And we found documented that there was purulent drainage around the catheter site, right? And we already documented previously that the resident had an indwelling catheter in place. So once I make those two selections and that meets SUTI, this will populate it as this resident has a SUTI. If you enter the criteria and this doesn't populate, that means the criteria that you entered do not meet NHSN criteria. So either you have to go back to the documentation to see if there are other criteria that do meet, or you should delete the event altogether. Because if you save this without this being populated, the application will allow you to save it. But guess what you're going to run into when you log back in? Those alerts. And you're going to, what did I do wrong? And it's going to force you to either update this or just delete the event altogether because it doesn't meet criteria. Once you select that, it's going to ask if the resident had a secondary bloodstream infection, and what that means is was there a matching blood culture. So if this is an ABUTI, you're going to say yes. Otherwise, it's probably going to be no. But if you do know of a positive blood culture with a matching organism, select yes. And then was that resident transferred to an acute care facility within 7 days? Yes or no. And then optionally, did the resident die within 7 days of the event for any reason? It doesn't have to be related to the UTI. But again, you'll notice that there's no red asterisk here, and that's an optional question. And then you come down to selecting the pathogens that were identified. So remember, you can only select up to 2 because any more than 2 in a urine culture will not meet criteria. So you select your pathogen, and then it will populate the antibiogram section for you to select. And I just want to point out here, so S is for susceptible, I is for intermediate. So you see here, R is resistant, and N is non-tested here. So this little box is on the form. If you run into forgetting what these mean, just look on the form and you'll see the box with a little key for you. If you have an organism, let's say a Proteus, because we do know that, or we've actually been seeing Proteus in the urine cultures in long-term care residents. And this was not common when NHSN, this antibiograms were originally built. And so when you put in Proteus, what's going to populate here is pretty blank. I think maybe one drug comes up. But what we ask you to do is that when you have your urine culture report, if there's drug susceptibility results on drugs that are not in our list, we ask you to add that drug for us. And this is good for you as well as for us because it allows us to assess what are the prevalent organisms that we're seeing in the field. And actually, Nicola's team found from the prevalence survey that Proteus was one of them. And we're in the process of making updates in our application, but any type of update like that is a pretty big update, so it's going to be a process. But in the meantime, if you see an organism that the drugs don't match or there's additional drugs that your laboratory tested, you just click add and it'll be a box and you can type it in and then select the susceptibilities. Here are the custom fields again, just like on the lab ID event forms, you have the option to build in custom fields for your urinary tract infection forms. And then you have the free text comments, and then just be sure to select save.